Bom dia a todos aqui no Brasil. أهلا وسهلا فيكم بلبنان. كما welcome everybody. اليوم اجتماعنا مع أحبائنا من لبنان, nosso encontro com nossos amigos do Líbano e representados pelo professor Michel Mawad. وهوني جريجوري هون صاحبنا بيعطينا أسامي بعض الحكمة من لبنان. دكتور صفدي منا هاي صفدي كيفك؟
هاي كيفكم؟ بون ديا.
Bom dia, bem-vindo. فاندا بيراد. حطوا الفيديو لنشوفكم شوي. اللي عنده فيديو يدور الفيديو عمل معروف. إليزا غرين. Vanda Beirada, ahlan sahlan. Bem-vindo, João Saba. Liga seu vídeo, João.
Tudo bem? Como é que você está?
Bem-vindo. Tudo bom aí?
Graças a Deus, tudo bem, pô. Tudo bem, e vocês?
اللي ما بيعرفوا جوان سابا من
Tufik, كيفك؟
البرداوني.
Walid, como está?
Bem, obrigado. كيفك حبيبي؟
Graças a Deus, pô.
أهلا وسهلا فيكم.
Obrigado.
Vou fazer uma pequena apresentação, embora já apresentei em português, sobre o professor Jorge Mawad. Ele é o titular da Universidade Libanesa Americana. Lembrar que tem duas universidades, tem a Universidade Americana de Beirute e a Universidade Libanesa Americana. E eu convidei o Dr. Mawad para falar um pouco sobre o Covid, a situação do Covid no Líbano e um pouquinho sobre o Oriente Médio. E aí convidamos também várias pessoas do Líbano. Eu até não conheço muitos, né? Mas todos são bem-vindos e um bom início de intercâmbio de conhecimentos entre nós e a universidade, assim como havíamos iniciado através do Jihad, o contato com o São São Jorge e a Universidade de Balamand, né? Vou falar um pouquinho árabe. أهلا وسهلا فيكم بلبنان.
Bem-vindos.
بدنا نخلطها شوي برازيلي وعربي وانجليزي. لنا شرف.
احكي برازيلي على مهلك بس لنفهم عليك.
اوكي. اليوم يعني بنبدا الاتصال بين البرازيل وبين لبنان مره ثانيه اللبنانيه المكانيه ومتمسك اليوم ميشيل معوض بده يحكي لنا عن الكورونا فيروس بالشرق الاوسط. ان شاء الله يكون ابتداء لعده اجتماعات بين الجامعات اللبنانيه مثل ما بلشنا السنه الماضيه مع جهاد مع المستشفى سان جورج والجامعه البلبند، حكينا مع كمان اللي وراء والجميع. هون الجامعه اللبنانيه اهلا وسهلا فيكم. Welcome everybody. Professor Mawad, كلمه لك.
Thank you so much. Can you hear me okay?
Yes. عملوا معروف الكل شيلوا الصوت شيلوا الساوند بلا صوت مشان ما نزعج الفلسطينيين.
Okay. Bon dia. Thank you. Thank you so much for asking me to address your society, l'Association Médica Líbano Brasileira. C'est un plaisir pour moi de contribuer à cette association et de participer dans ce meeting cet après-midi, dans ce Zoom meeting. I'm happy to join this meeting and to share with you, to some extent, the situation in Beirut and in Lebanon with what is happening with the COVID-19. It is a pleasure to be with you, and as Dr. Nemer said in the beginning, we look forward to continue a collaboration and cooperation between the Lebanese physicians and the Lebanese American University the Lebanese American University Hospitals, and the Lebanese American University Medical School to contribute as much as we can and to establish a link and a collaboration between our friends, our Lebanese friends in Brazil, especially the physicians that I know so many of you, through the Associação Médica Líbano Brasileira. I'm going to share with you my my screen, if I can.
Okay, you can just put it.
Yeah. Can you see it? Can you see the screen? Can you see the presentation?
No, not yet.
Okay, it may take a minute.
I can't see it, Dr. Mawad. It should be in there. This is Dr. Hashim.
You have to share.
Yeah, hey, Ray, how are you? Can you see it?
Yes, I
Yeah, so Ray Hashim from Houston can't see it.
We can see it from the Shuf Mountains.
Okay,
Oh, wow.
The Shuf can see it. Sao Paulo has not reached Sao Paulo yet. Sao Paulo is far away. Robert, can you see it?
Yes, I see.
Okay.
Okay, let's go.
So as I said, I wanted to thank every one of you, especially Dr. Nemer for putting this together. And again, I'm happy to be together with my friends from Brazil for all four corners of Brazil. I'm going to give you a very short status of the COVID-19 in Lebanon today. What's happening in the country, what did the official government do in the country for COVID, what the private and public hospitals have done, and specifically what our institution, through our hospitals and infectious disease group and our medical school have done to help in the containment of this pandemic in Lebanon. I must tell you that today, Lebanon is going through some difficult times, not only because of COVID, but a combination of things, among them the COVID-19 pandemic, but also the economic situation in the country. The economic situation is very bad, and that is aggravating the COVID-19 pandemic. As you know, the Lebanese are very much extroverted people. They like to go out, they like to party, they like to have dinners in families and with friends. They like to smoke argile in the evening, but they like to socialize. So this is not the kind of people that can be confined at home. So what did the government do? This is from the website. If somebody, I think people have to mute their mics. If people can mute their mics. So this is from the website of the Ministry of Health in the government. This is taken yesterday. If you see, this is May 29th. Robert, if you can ask them to mute their mics. So this is from the website of the Ministry of Health, and this was as of yesterday, May 29. You see that the total number of COVID-19 patients in the country is 1,172 patients proven PCR positive. Robert, somebody has to mute their mic.
Stai guardando?
No, no quel di
Robert,
Pietro,
can you
quel
ask
da
them to
Libano.
mute their mic?
Dopo Pietro.
Okay, so this is from the official website of the Ministry of Health in Lebanon. This number is the total number, 1,172 patients in Lebanon. Lebanon is now about 6.5 million people between its Lebanese citizen and the total number of refugees in Lebanon.
In arabo anche.
So we have about 1,172 people with PCR positive. These 213 of those have come from outside, have come from Europe or from South America or North America or the Arab countries. Yesterday, for instance, the number of PCR positive were only 4 in the entire country. So the numbers have actually settled down a little bit. This here, the 80,239 are the number of PCR testing that has been accomplished in Lebanon through various authorities, through the government, through Rafiq Hariri Hospital, and through some private hospitals and private institutions. There are about 6,650 people in quarantine, about 26 deaths already, 26 deaths from COVID. And the testing is divided primarily about 70,000 in Lebanese, regular Lebanese living in Lebanon, and about 11,500 people coming from outside. So this gives you a snapshot of the status of COVID today in Lebanon. The government has done pretty well, actually. There is a lot of criticism of the government for them not being able to handle the situation. In my opinion, given the resources and the economic situation that is happening in the country, I think the government has done as good as expected. So they have a lot of, on their website, a lot of activities that are oriented towards the patients and the general population. This is from their website also that explains what is the virus COVID-19 and the symptoms, and how does the virus how does it transmit from one patient to another? Is there a treatment for corona, for instance? Is there a vaccine for corona? And what is the incubation period? All of these are part of the efforts that the government is doing to educate the general population about COVID. Obviously, there are a lot of other activities done by other hospitals, by non-governmental organizations, non-profit organizations, that are also complementing what the Ministry of Health is doing. There's also quite a bit of information of how to avoid the infection, what to do with the infection, where to go for testing, and supposedly all tests that are positive are reported to the Ministry of Health in a national depository of the number of patients. There are many other activities, many brochures, media campaign, many audiovisual campaigns, again, undertaken by the government and undertaken by several non-profit, non-governmental organizations. For instance, these are folks, this is Walid Ammar from the Ministry of Health. This is Dr. Bezri from the Ministry of Health. This is Rita Dumid. She is the Na'ibat al-Nursaid. She's the president of the Society of Nursing in Lebanon. She is a faculty at LAU. So there are many activities and many social media activities and many audiovisual and electronic pamphlets that are that are made available for the general population to be educated about the virus itself. So in my opinion, even though the government could have done better, I think what they have done so far has resulted in reasonable results with very limited number of spread of the virus among the general population, keeping in mind that they also brought, and they feel obligated to bring quite a few Lebanese expatriates, especially students that are studying and pursuing their studies in Europe and in North America and South America and Canada. They're also bringing expatriates, Lebanese people who live in the Gulf countries, in Saudi Arabia, in United Arab Emirates, Kuwait. They also feel obligated to bring them back to the country. There was a mishap in the beginning. I think the government messed up. The original few plane loads that came, they came from Iran, and Iran was a big hotspot for COVID-19. There were a few plane loads that landed in Beirut Hariri airport, and the people just got off, and in my opinion, were not handled properly. So there was an early spread of the virus from expatriates coming from hotspot countries that were not quarantined properly. And in my opinion, the government was just not ready and did not have the resources or the facilities to quarantine these people. So therefore, there was an uptick in the spread of COVID-19 virus, not among citizens living in Lebanon, but among people coming into Lebanon, especially Lebanese living in other countries. The way the government and the hospitals, the private hospitals, tried to handle the situation. You know, we have one main large university government hospital in Lebanon, close to the airport, that was actually built under the time of Prime Minister Rafiq Hariri, and that's called the Rafiq Hariri Governmental Hospital. It is actually, that hospital is taken in charge by 2 or 3 universities, including American University of Beirut, our medical school and our university, and the Lebanese University. Residents and attendings from various universities actually run that hospital. They have a very good director, Dr. Abiad, and they also have a medical director, and they also have good infectious disease section. So that hospital, Mustashfa Rafiq al-Hariri al-Hukumi, or Rafiq Hariri Government Hospital, is really the main hospital designated by the government to triage, test, quarantine, and also treat patients with COVID-19, but especially sick patients that need assisted ventilation. There are several other governmental hospitals throughout the country that were also quickly equipped with all the necessary equipment and material to handle COVID-19 with more or less some varying or variable level of readiness. We as a university, LAU, and our hospital and our infectious disease folks and the medical school helped one of these government hospitals to get ready for COVID-19, and in fact, it worked very well. There are several other hospitals. There is one in Tripoli, there is one in Jbeil, one in Baalbek, one in Psharri, close to Ariz, some in the south, مستشفى نبيه بري الحكومي بالنبطية، مستشفى بنت جبيل، مستشفى فتوح كسروين بالبوار، مستشفى حلبة. Mustashfa Saida. So the government tried to equip and get some of these government hospitals outside Beirut to get ready to receive patients suspected of being COVID positive, to triage them, test them, do the PCR, quarantine them if necessary, and treat them and admit them if necessary. There is a shortage of respirators in the country. So at one point in the beginning of the pandemic, we were very scared that we might run out of respirators if we get flooded by severely ill COVID-19 patients, i.e. those requiring assisted ventilation. Luckily, this did not happen. Luckily, there were not that many cases. As you saw, the number of deaths since the middle of February and beginning of March, the number of deaths in Lebanon, COVID-related death, is only 24, which is a relatively small number. For some reason, we are not seeing very severely ill patients in Lebanon. I don't think anybody knows the reason for that. Maybe we're not testing enough, and we know we're not testing enough, but also it seems like the acuity of this patient that we see is not very high. And we have a fair number that are becoming COVID PCR negative, so they're basically on 2 repeated testing, they become negative, and therefore they're being labeled as cured from COVID. So overall, the rate of death is low, and the rate of very sick patients from COVID is low when you compare them, say, with the US or with Iran or with Italy or with England. We hope that is the case, and we hope that with time, we don't see a transformation in the acuity of these patients. Our hospital, as I will explain to you later, our hospital number 2 on the right from the top, the LAU Medical Center Resident Hospital, has contributed to the community and to the society in a variety of ways, which I will elaborate on in a couple of minutes. But our hospital, very much like any other hospital, is ready to receive patients with COVID-19, but also, most important, to triage patients and to do the PCR testing. And I will show you in a little bit also that we did not limit ourselves to the hospital, but we went outside the confines of the hospital. We went into all 4 corners of Lebanon, from north to south, from east to west, to go and test patients way out in the periphery, as I will show you. So this is what we did in our hospital. First, as you know, we did not have enough rooms, inpatient rooms, that are negative pressure equipped. So we converted half of our ICU to negative pressure rooms, and we converted 2 full floors to negative pressure rooms to be able to admit safely patients with COVID-19. So these are the work. We had to change all the ducts, and many other hospitals have done the same thing. We had to change the ducts, separate the aeration and the ventilation between rooms, and carry the exhaust out all the way to the roof of the building. This is our hospital, where we had to do the negative pressure, change the ducts, change the ventilation, add filters, and carry the exhaust out above the level of the roof of the building, just to make sure that when a patient is in a negative pressure room, when a COVID-19 is a negative pressure room, we minimize the contagion and the infection of the healthcare personnel, primarily our nursing staff and also our residents, fellows, but most important, our frontline physicians that are the infectious disease people. So this is what we did, basically from A to Z, ripping everything out from the walls adding negative pressure, and adding exhaust system above the roof at a very high cost. This was not only us, but all hospitals in Lebanon that had to do this. This is an extra expense item which was not on the operating budget. So needless to say that the COVID-19 is really taxing all of these hospitals and our health facilities, is taxing them not only by the lack of patients, of regular patients coming in, but also is a big burden financially and on the operating budget, especially in this difficult period of time in Lebanon, the difficult financial period of time. In addition, with the help of the Chief Medical Officer, Dr. Ghanem, with the help of Mr. Saad Zain and the steering committee and the infectious disease personnel, we put together quickly a mobile clinic. This is a truck that was donated by some healthcare companies and by the Czech Republic, by the embassy of the Czechoslovakian Republic in Lebanon. They gave us a donation. We quickly equipped this clinic, which is called the COVID-19 mobile clinic. And we said we're going to do the following. If the patient cannot come to the hospital, we take the doctor and the testing to the patient. Because patients are very scared to come to the hospital. And also we wanted to minimize the risk to our frontline healthcare professionals and physicians, specifically the emergency room doctors and our own doctors. And we said we will equip a small team like you see of technologists, lab technicians, doctors, he's the Dr. Ghanem and Dr. Safadi here, to get in a convoy, and they go from one corner of the country to another and test patients who are either suffering from COVID-19 or may be suspected of having attracted COVID-19. And we set out to crisscross the country with this mobile clinic. We only have one mobile clinic. We are hoping to acquire a second one, but we went all over the place and we continue to go. We will set schedules and we will assign teams from driver to nurses assistant, to laboratory technicians, to physicians, to go and do the PCR testing, screen these patients, get a short history, get the PCR testing on these patients, at least the samples, usually nasopharyngeal swabs, and bring those swabs to our main laboratory to check for PCR. So we do the PCR testing at our hospital, and all of this was free of charge. We did this testing, the whole operation was free of charge. How did we do it? We solicited and received gracious, generous donation from many people, and banks, institutions, individual donors, companies that covered to some extent the expenses of this campaign. So the criteria to go for these visits, we coordinated with local authorities, primarily with local government hospitals, those hospitals that I showed you. If there was no government hospital in the area we were visiting, with the municipalities or the emergency unit in each country. For instance, we went to Sharri in the north, where there was a cluster of COVID-19, and we coordinated this with their local hospital and their municipality. If none of this was available, we did that with primary care bodies or non-political, non-governmental organizations. There were patients and appointments were organized by any of these entities. We partnered with them when visiting a particular place. We would do free PCR testing per village, ranging up from 25, and sometimes we would reach 75 to 100. And the people to be tested, or the people that we targeted to test in the periphery and throughout the country, were those who might have symptoms or think they are symptomatic, people who have been exposed to patients affected with COVID-19, especially elderly people or immunocompromised patients, people exposed to potential patients, especially healthcare workers, the healthcare workers in the various hospitals that we went to, because we wanted first to protect the healthcare workers and to avoid what happened in Italy, where the frontliners, the physicians, the nurses were the most hit in the beginning. We wanted to protect at least the healthcare workers in the beginning to keep them functional and keep them working on the front line. And the numbers have really multiplied tremendously. This is a picture of the mobile clinic going up in the north, among the forest up there. We went to Baalbek, and you see the Baalbek in the background. We went to Rashaya. We went to the south all the way to the border, and these are the vehicles of the UNIFIL, the United Nations Force for Lebanon, right to the Israeli border. We crisscrossed the whole country. We went to Batroun. This is Tanourin Hospital, up in the Jirid of Batroun, very high up. It's a very busy local government hospital. We went to Akkar, to Bayet twice, and we did a lot of testing. When I say we, it was mostly, not myself, it was mostly the chief medical officer and Dr. Mukhbat, the head of ID, and Saad Zain, who has organized all of this. And on those trips, not only would we do the testing, there were also sessions to educate the local folks, the local healthcare workers, to show them how to contain infection, how to test for infection. This is in Mashghara. You see the Buhayrat al-Ar'un behind it. This is all the way in Bi'a al-Gharbi, in western Bekaa towns and villages. You see Dr. Jacques Makhbat, who is the head of infectious disease, a world-known authority on AIDS and infectious disease. He's the chair of the Department of Medicine at LAU, and he's the head of infectious disease. And you see Dr. George Ghanem, who is our chief medical officer. So there was a lot of investment of time and energy going throughout the country, free of charge, to help do the triage and to contain the disease. We wanted to do as much testing as possible, isolate the PCR positive people, quarantine them, and avoid infection and contagion. And I believe we really helped, because we see now the number, as you will see in a couple of minutes, the number of COVID-19 has stabilized. We also did it in the cities. We did it in Beirut. We did it with the municipality of Beirut. We did it in Ashrafiyeh. We did it in Saida. We did it in Zahli. We did it in Tripoli. We also targeted the highly densely populated urban areas and city areas. And again, Al-Fahas Majani, it's a free of charge PCR testing. And we also, in parallel to the government, because the government, as you saw from the first slide, they issue their own report, their own daily report of the number of COVID-19, the number of testing, and the number of positive, number of negative. We also did the same thing. We tabulated our data daily. Daily, we tabulate our data for all the PCR testing. And you see several bar here. You see the total number. The positive is yellow, is very low, because the rate of positive to the whole testing number does not exceed 1.5%. I will show you. But we tabulated this data, And we communicated this data to the Ministry of Health. And you see here, for instance, number of patients tested for COVID-19. I don't know the date when this was taken, but this was a daily upgrade of these numbers. And clearly you see some troughs, you see some low numbers. These coincide with Sundays, with weekends, because we did not test, the lab did not run on weekends. And you see, for instance, between the 16th of March to 17th of April, you see the number of tests is going up significantly. So we tried as hard as we can to increase the number of tests. The COVID-19 PCR test in Lebanon cost about $100, at least when the dollar was 1,500 Lebanese pounds. But you know, the value of the Lebanese pound has really gone down significantly. And so the price of the PCR testing is kind of steep for people who are on modest means. But it is about it used to be 150,000 Lebanese pounds, or the equivalent of $100. And I believe our hospital, for the inpatient and for not for the mobile clinic, as I mentioned, that is free of charge. But in the hospital, we charge about 150,000 Lebanese pounds. Today, the dollar, the US dollar, is about 4,500. So, we still charge $150,000. We also did something which I think is very useful. In addition to upgrading our rooms, our wards, ICUs, our ERs, we upgraded everything to be negative pressure, and to be able to triage COVID-19 patients or patients suspected having COVID-19 in a separate room from the regular population. We also, between the medical school and the hospital, we established a corona teleclinic. There was a schedule, and there continues to be a schedule of physicians actually running or answering emails, phone calls, and chats for any patient or any individual throughout the country who is worried about having contracted COVID-19, or who might have contracted COVID-19 and doesn't know it and wants to ask questions, or somebody who may have symptoms and doesn't know if he has COVID-19 or she has COVID-19 or has a regular flu, or patients inquiring as what to do next, where to quarantine themselves, what to do with their elderly parents in the house, because you know, in Lebanon, the vast majority of the elderly parents want the children, or where to go for testing, or is it necessary to be tested? So under the aegis of the medical school and the hospital and the physicians at the hospital, we established a teleclinic, sort of a telemedicine, but we did it from scratch. We did it with no help from outside. We did it through our IT department, and we established two kinds of schedule. One schedule for a physician to answer the questions, and one schedule for what we call an administrator, who's a secretary or a staff member, who would help coordinate this. As I said, this was phone calls, phone banks, chats, or emails. Sort of like in-house telemedicine, specific for Corona teleclinic, to supplement our inpatient facilities and to supplement our reach out mobile clinic. Let me finish by a few of these slides. We have at the Lebanese American University, specifically in the School of Arts and Science, and also that person has a second appointment at the School of Medicine. His name is George Al-Khazin. George El-Khazi is a superb statistician, a biostatistician actually, and he works with our researchers in the School of Medicine, and he's really an authority on his own in statistical analysis. This is his website. I am using a few slides taken from his website. And the idea on the website is you can hover over any country. He clearly hovered on Lebanon. You can hover, you can put your cursor on any country and gives you instantaneous statistics. For instance, in Lebanon, the total test at the day this was taken, and I don't know when there were 77,000 tests taken. There was, on that day, a cumulative number of 1,161. But most important, the rate of positive PCR patients over the number of tests. And here in red, it gives you the daily positive case, and you can see the wave. It goes up and then started coming down, and then it started going back up again because of the influx of expatriates. So, and down below is the daily number of tests. We need to know how we're doing in the country in terms of daily number of tests. And you see it fluctuates. Again, the troughs are on weekends, but clearly there is a pattern of increasing the number of testing. So we can give at any given time in any country through this website of Dr. Khazi the total number of tests, the total number of positive cases, the ratio of positive cases over the number of tests, and then we can extract the data, the daily positive cases, and the daily number of tests. And then this one is the cumulative positive test. And as you see, we had first, this is in March, April, May, we haven't reached June yet. We had a huge uptick in the beginning, mostly because of a few patients that came from Italy and from Egypt and from Iran. They came in infected, and people did not know about it, or they went and mingled with their communities, and there was really a surge in the number of cases. But you see here the cumulative number of positive over test is going down, which is a good omen, which is a good sign. Again, the daily positive went up and then came down, we're coming up from those expats, and the daily number of tests also has gone up. So all of these actually are good indicators. That's why, in my humble opinion, I'm not too harsh or too critical of the government, because they really, given what they have in terms of resources and the status of the government hospital that exists in Lebanon, this is not bad so far. We hope and we pray that it doesn't change. Again, this is the daily positive test, and also the same thing here. Now, these are the cumulative tests per million. We are not testing as many as we should test. You see here a total number of 77,000, and the test per million is 11,300 roughly. And this includes everybody. When we say per million, we count the entire population of Lebanon, both Lebanese and residents or refugees, non-Lebanese. We estimate the number of refugees altogether about 2.5, and the number of Lebanese about 4 or 4.5. So we are averaging about 11,300 tests per million. And now you will see in the next couple of slides that we're really on the lower scale of that. And mostly it's a financial situation. You will see that the wealthy countries are testing much more than us, and the poor countries or not as wealthy are testing according to their means, because we have to pay for these tests. All of these tests are imported. Unfortunately, we have no way to manufacture the PCR testing in Lebanon. And this is the cumulative test per million. The entire number of tests has gone up per million, but we're still testing a relatively small number per million. The entire number of testing has gone up, but per million is not enough, in my opinion. This is you see the daily test per million. It has gone up a little bit, but then it drops down. And this also corresponds, you will see that the more you test, the more positive tests you're going to pick up. And then you reach an equilibrium where you then know that this is the rate of infection in your country. So as it stands right now, given that we are testing only 11,300 per million, the ratio of positive to every test we do is only 1.5%. And the death rate altogether here is below the international average. We only lost so far 24 patients. We have a few critical patients hanging in hospitals, but it seems like the number of deaths from corona has taken. I don't want to depict a very nice picture, but nevertheless, in my opinion, things almost have stabilized, unless there is a big wave that comes in the summer, or as infectious disease folks predict, maybe around the beginning of the winter, November or December. These are the daily tests per million, and these are the cumulative tests that are positive. So I don't want to bore you too much with these numbers, and I want to end with these couple of slides. You see here, the red is Lebanon, the blue is Jordan. This is to locate Lebanon in our environment in the Arab world. So we have Lebanon, Jordan, Bahrain, Qatar, Saudi Arabia, and United Arab Emirates. Clearly, we don't have data from Iraq, we don't have data from Yemen, we don't have data from Syria. But these are the cumulative positive per test. You see that the percentage of positive in the tested population in Qatar is very high, 24%. They have a large number of expatriates that work there from Southeast Asia mostly. But really the number is high because they're testing quite a bit. The more you test, the more likely, in the beginning at least, until the population stabilizes, the population of COVID positive, the more tests you perform, the higher the number is. Lebanon, as it stands today, is 1.51% or 1.5% of all tested. But again, this also might be a reflection of the fact that we are not testing as many as our friends in Saudi Arabia, who have much more resources than we do, or Qatar, for instance. You see, Qatar, Saudi Arabia, and Bahrain are higher because they test more. And this is, here you see also the daily positive test, the same thing. You see Qatar, you see Saudi Arabia, you see Bahrain. There is always an uptick in them because the number of tests in those countries is high. This is the daily test per million. Again, Lebanon is the lowest, 245 per 0.41 per million. And if you go up, the number goes up. And Saudi Arabia, look at Bahrain, for instance, which is green. United Arab Emirates, these are wealthy countries. A small indigenous population, but very wealthy GDP, very high GDP. so they can afford to spend. And actually, the United Arab Emirates is very, very well organized. They almost force everybody to be tested. And this is the cumulative test per million. As we said, in Lebanon is about 11,300 per million. And this is 11,000. And you go to United Arab Emirates, is 210,000 per million. 21% of their population is being tested. Bahrain is 17% is being tested, and so on and so forth. Just to give you a snapshot of what's going on in the Middle East in terms of COVID-19. So that was a short summary of where we are in Lebanon. I think what's hurting us the most is not COVID, really. What's hurting us the most is the economic situation. We are trying hard, all of us, to survive this kind of destiny that was imposed on us by really the pilfering of the government treasury. All of us, physicians, nurses, engineers, all of us as citizens are trying the darnest best we can do to get out of this. We will get out of COVID, and we will get out of the financial situation. We never give up around here. And you are Lebanese, you know that we don't give up. Your mother and father did not give up. Your grandmother and grandfather did not give up. So please, look at the bright side of things. As soon as it's safe, come visit with us. The sunset is always beautiful, but the sunrise is even better. And I want to end up to cheer you up a little bit.
Oh, Professor Michel, the sound, please. Professor Michel, já me esma.
Yeah.
Agora ri, hala é.
Are you hearing it? Can you hear it?
We are hearing, yes. Continue, please.
Okay.
But not the video. We are hearing your voice, but not the video.
Can you hear the music?
No, no. I think you gotta turn it on.
No, it's on.
Oh my goodness.
The sound is not good. Only your voice, not the music.
I'm so sorry.
No
But
worries.
this is Colonel Al-Watan. I want you to come back home.
I will find it for you.
So, but it's very interesting. This is a recent version. And if you look carefully, if you listen carefully to what they did, and I think this is the only one that I've ever heard where they say, Mambitun lin-nisa war-rijal, the first time ever, because the Lebanese woman is becoming stronger and stronger in Lebanon, and that's a good sign.
Very nice.
Okay.
You have to translate.
I can stop here and I can take questions if you want to.
Okay. Professor Michel, thank you very much. Se alguém quiser fazer uma pergunta, quiser fazer em português, a gente traduz em árabe. Any question from somebody else from Lebanon or from Brazil? And we would like to hear something about Lebanese doctors. Please, you may introduce yourself and you say anything about that.
كل شيء اوكي. Very clear. شكرا حبيبي.
Robert, gostaria de falar alguma coisa pro...
Yes. Oh, yes.
Marhaba. C'est un plaisir de vous recevoir ici au Brésil de nouveau. Hein?
Férez.
Marhaba, ya Ustaz.
Hey, good to see you. Good to see you, Habibi.
C'était un plaisir. Et aussi de cette information à propos du Covid au Liban, ça nous donne une bonne situation, je pense, à cause de notre famille qui habite au Liban. Et je veux bien que vous travaillez encore et encore plus. Et ça nous donne beaucoup de satisfaction. Hein. Merci pour votre...
Je t'en prie, c'est un plaisir pour nous. C'est un plaisir pour tout le monde et pour l'équipe à l'EU.
OK. Il y a quelqu'un qui... Est-ce que...
Rodolfo Rodrigues, déjà désactivé.
OK.
Continue.
Est-ce que vous pouvez nous dire quelque chose à propos des strokes, les malades avec le Covid, avec les strokes?
Yeah. So,
in English.
Dr. Elias is asking, because he's an interventional neuroradiologist like me, I have a lot of very, very good Brazilian friends who are excellent, just excellent interventional neuroradiologists. Unfortunately, we lost one of the best, Ronnie Pisky, who passed away not too long ago. And so what Elias is asking me about the effect of COVID-19 on stroke. We actually have seen in Lebanon, in our stroke center, and probably throughout the country, because we do more stroke than anybody else in the country. We saw, unfortunately, a drop in the number of acute stroke coming in for several reasons. I think a lot of people are scared of coming to the hospital, even though they may be experiencing signs and symptoms of stroke. So we saw a dramatic decrease of the people showing to the emergency room. They come in late, Elias. They wait a long time, and you know, the circulation is not good. At one point, the circulation was not good, and it's still, the circulation is not, it's not the usual case of traffic. So they come in finally, but they come in too late, way beyond the window. And you do a rapid scan, or you do MRI or CAT scan mostly, you see a large stroke with a large core infarct and very little penumbra. So we did not, we did not jump in on those cases. There is an effort going on now, which we participated in, is to spread a little bit, حملة توعية يعني, pour éduquer les gens de nouveau, comme quoi il ne faut pas rester à la maison quand on a un stroke, il faut venir à l'hôpital, même si dans ce temps de COVID-19. At the hospital, we also divided it in half. We still had coverage, but not a full team like we usually do outside the COVID-19. But we saw a lengthening of the time, door to needle, door to groin, and door to thrombectomy also, because they come in late. And also even in the hospital, because you have to do PCR testing, you have to wear the PPEs and all of that, and that takes some time with patients. But last week we had 2 or 3 cases, I think, of stroke coming in. So it's starting to pick up again.
Thank you.
More question, please. Anybody else?
Yes, I want to make a question. First of all, Professor Mawad, it's a great pleasure for us having you with us. And I really appreciate your conference, your speech. And I would like to ask you, you are showing very good results, amazing results. And what's your strategy for treatment during the acute phase, during the very beginning, and during the inflammatory storm. What's the Lebanese strategy in terms of drugs therapy?
That's a good question. You know, I'm not showing, I did not imply that our good results or the low rate of sick people is a measure of success. I did not imply that. I just showed you the numbers, that our positive to a cumulative number of tests, our number of positive cases to the number of tests is 1.5%, but probably because we're not testing enough. But it seems like we are not seeing that many very sick patients. They come in, they're positive, but not all, very few are requiring, at least in our hospital, are requiring assisted ventilation or admission to ICU. That's different at Hariri. Hariri Hospital is the main government hospital who's handling this. So I suspect they're seeing a higher acuity of patients. As how we're treating them, you know, I am not the infectious disease expert, but I think in the beginning there was a lot of enthusiasm on hydroxychloroquine, as advocated by Professor Mawad and by Professor Donald Trump. So, but in the beginning, we almost lost the hydroxychloroquine from the shelves. In the pharmacies, everybody ran and bought as many number of boxes and put them in their homes, thinking that they might need them. But now the jury is out that hydroxychloroquine is not as effective as initially thought, but maybe might even be not good for the heart rate and for the myocardium or what have you. I believe they are using here remdesivir, one of those anti-corona drugs, and there is now new evidence that a short course of steroids in the beginning is actually beneficial, contrary to the initial thinking that steroids might actually aggravate. I saw a report from Dr. Husni yesterday saying that now thinking that perhaps in the early phase of the corona, Dr. Husni is our infectious disease expert, that maybe a short course of steroids in the beginning, and was thinking that there is a diffuse coagulopathy as a systemic disease of COVID-19, which might be affecting the lungs. And a lot of what we're seeing in the lungs might be actually pulmonary emboli, not necessarily direct infection on the lungs. So there are people who are starting to use anticoagulation for this. And also not to increase the pressure of the ventilation, not too much positive pressure, but rather regular normal pressure of the ventilator, and not to keep them super for too long, even in the beginning. But I believe we have Dr. Ray Hashim, who is the expert in infectious disease from MD Anderson Hospital in Houston. Ray, are you with us?
Well, I think he has already left because he told me yesterday night he would have an appointment at this time. So I think he's not with us anymore.
He's not, because he is in a funeral. Sorry, he's not online.
Yeah.
Let me ask you one more quick question, if you don't mind.
Okay.
Okay. First of all, I am a cardiovascular surgeon, and as a surgeon, we are trying to reestablish the elective program at our institution, at the Heart Institute, University of Sao Paulo. And I'm really concerned about this because we are losing patients that are afraid of coming back to the hospital for emergency care related to other diseases rather than COVID. And do you have any protocol, or are you planning any protocol to establish the elective surgeries back again?
Yeah, we do, but and I know the answer, but I would like Dr. Safadi. I think Bassem Safadi is the chair of surgery at our institution. Maybe he can give us quickly the plan of re-entry into the surgical OR schedule. Bassem, can you comment on that?
His microphone is off. Yes.
Yeah,
Okay.
Bassem,
Yeah, I
turn your
just turned it off.
microphone.
Yes.
Yeah.
Can you hear me?
Yeah,
Yes.
we can.
Yes, Bassem. Hello, sir.
Very good. Well, hello, everyone. Thank you, Dr. Nemer.
Hello, sir.
And I'm very happy to see Gregory. Gregory was one of our residents.
Yeah.
He is extremely happy in Brazil, and I also want to thank him for inviting me. It's great to see you.
Great to see you too, Doctor.
We have resumed elective surgery about 10 days ago, and we expect to be fully operational in about a week or so. What we are doing is carefully screening all our elective cases by first a very careful history, and then what we do routine PCR on every patient, and that's how we screen patients. As far as emergencies, we categorize them. So if it's a life-threatening emergency, obviously we don't want to wait until the PCR is done. We take our precautions as if the patient has COVID, so we use the full PPEs and we proceed with surgery as planned. If it's an emergency but can wait 24 hours, we do the PCR testing and we postpone the operation, like appendicitis or cholecystitis or certain cases that can easily be held off for 24 hours.
All right, thank you.
Let me add something, that when Dr. Safadi and the hospital administration put the schedule together, they started first by 25, 50. They did a gradual coming back to the OR schedule. I believe they are up to 50% of the normal OR schedule pre-COVID-19. But gradually they will ramp up to go to 100%.
Thank you very much.
You're welcome.
I would like to say something to Dr. saying here. Patrice Nasnas, I invited your father to come in here. Unfortunately, he's not here. So say hello for him, and we hope we meet you and him in the next meeting.
Thank you, Doctor. I will be sure to pass the message. I wanted him to join with us, but unfortunately, he got caught up with an emergency today. That's why.
That's okay. Thank you very much. Dr. Gregory, he has a question, please.
Bom dia a todos. Dear Mawad, thank you a lot for the presentation. I'm Gregory Nicholas. I'm an LEU alumni as well as I did the general surgery under our great chairman, Dr. Safadi. And I want to thank Dr. Nemer, the president of the association, as well as the previous president, Dr. Hinato Asad, who are doing a great job to hold the Lebanese roots here in Brazil among the doctors. And it's a great association. So my question is, what do you think is going to happen right now since the country is opening up? What do you think is going to happen? Is Lebanon ready for the opening up, which is happening right now? Compared to the quarantine, Lebanon was doing very well, but now it's opening up. What will be the situation in a week or two? What will happen? This is my main question.
Gregory, I would like to complete your question. And especially now you have a big popular movement in the streets. What will happen in Lebanon with that?
Yeah, I don't have the answer to the other side of the question that Dr. Nemer put on the table. Actually, the economic and social situation in the country is not pretty. It's not pretty at all. You really have to be here to feel it. As to what Gregory asked, what's going to happen in the rate of infection once they open the country, You know, it was supposed to open, the airport was supposed to open on the 8th of June. And it seems like now, I heard yesterday, they postponed it for another 2 weeks. Because specifically, they don't want a flood of PCR positive coming in. There's no question, once the airport is open, and there is a flux of people coming, both expat and non-Lebanese coming back to the country, there will definitely be an uptick in the number of PCR positives, and probably the infection rate will go up. However, we know that the government is not, and the government and the airline companies are not letting anybody board the airplanes without a PCR test that is negative. They don't let them board the plane unless they have a PCR test done already, no less than 48 hours from the time they board the airplane. And I believe they are repeating the test upon arrival to Beirut Airport. And those who prove to be positive, here's the weakest link in the chain. They used to tell them come and be quarantined in specific locations. I believe now they have loosened up and they're still allowing them to quarantine, self-quarantine at home. There was a guy who came from Nigeria about 3 or 4 weeks ago, who came back from Nigeria. I believe he tested negative, or anyway, he went back to his home village in Akkar and mingled with the entire village and many other villages around him. And he himself was the focus of secondary infection to at least 100 people, including people in the army. So there was clusters in the army and what have you. So the answer to your question definitely is caution and a worry about an uptick in the infection rate when they open the airport. Whether they will be able to implement the safety measures, i.e. PCR testing and repeat PCR testing till they become negative in case they are positive, and effective quarantine of people coming who are infected or will be infected or in the incubation period, that remains to be seen. It depends really on the government and on the security forces to enforce all of this. That's the best answer I can give.
Any more
good enough.
Robert, I am seeing Professor George Halak with us. Thank you very much for being with us. And I would like to ask you, could you please tell us something about the General Hospital at the University of Sao Paulo? What's going on? Because I know you are taking care in the front line, and maybe you can share with us your comments and your opinion about the strategy of our institution.
Well, it's a great pleasure. Professor Michel, it's an honor to listen to your conversation. We feel like not the distance at all, we feel like home. Yeah.
That was the purpose.
I was looking at everybody's faces here, and everybody looks like brothers, you know, so really it's no difference. So at the University of Sao Paulo, I'm urology, I do andrology, and I'm conducting a lot of research, both in patients as well as the patients that have disease. So we are looking at the testicular biopsies of patients who have disease. We have it's a huge task because the biopsies, these are level 3 infectious diseases when the patient has died. So we are doing minimally invasive ultrasound guide biopsies in the corpses, and we have looked at some of the testicular biopsies, and we have looked at there's a great deal of orchitis in the deceased patients. In the patients in hospitalized, we are conducting studies to check the hormonal levels, testosterone, and etc. We are also looking at the semen quality sperm of these patients to check for, as a cytokine storm, there's a big correlation with reactive oxygen species and lipid peroxidation, DNA fragmentation. That's the kind of stuff we are looking at patients. We have, and we are also doing PCR in semen to see if there is virus in the semen. And also after that, we are going to do viral culture in the semen to check for viability, not just the presence. So these are the things. In our hospital, we have a 900-bed hospital just dedicated for COVID-19. And at the moment, we have 560 patients in the hospital. The intensive care unit is 400 patients for intensive care unit. They are all 90% fully booked. So the problem here is that when most of the patients need intensive care units, so it's not just enough to have a hospital bed. Because when they need some, they go from zero clinical symptoms to very easily they need oxygen therapy and many times intubation. So the fatality rates, when they are in the intensive care unit, you have around 25% patients die, which is pretty good in consideration with other places like the general death toll for intensive care units in Brazil is 66%. New York reached 88% in the peak of the disease. So we are doing okay. What the lessons we are taking, that it's not just enough to have briefers and intensive care unit. You must have a very high qualified and specialized medical support so that the patients don't die. Is very critical, and each patient is different. We have a high degree of obesity among the main characteristics of patients who don't go well, besides cardiopathy. So obesity is gaining a lot of importance in Brazil, especially among the poor population, because it's becoming not like United States, but Brazil is becoming very fast an obese country. Let's say like that. So this is the endpoints I'd like to discuss. We will have our own research in the next 5 to 6 months, and to share about I'm interested in men's health, so I'm looking at the testicular and semen, reproductive and sexual issues. That's my goal, and we are pretty sure that we can contribute to some knowledge. But thank you very much for your lecture. It was a great pleasure to be among my brothers here and sisters.
Thank you very much.
Thank you, Dr. Halla.
We have a question from Dr. Ahmed Saleh من لبنان وهو بالبرازيل حكيم قلب جراح قلب. أحمد عمر معروف.
أول شيء طبعا بلبنان هلا صار مساء الخير دكتور ميشيل
مساء الخير دكتور أحمد، كيفك؟
الحمد لله، والف تحيه لكل الكوليجاز اللي عم يسمعونا. طبعا الاستاذ هوبرت بده يترجم له. دكتور ميشيل حابب اسال سؤال باللغه العربيه.
تفضل.
شو الدوله اللبنانيه اعتمدت لعلاج الفيروس كورونا 19 وشو كان عندها البروتوكوليشن تبعها هي؟ اي دواء هي اعتمدته، علما انه كل الدول العالم من اي دوله بالعالم اعتمدت دواء شيء. البرازيل مثلا اعتمدت الهيدروكسكلوروكاين، فرنسا وقفته. لبنان شو اعتمد؟ على شو اعتمد انه عم بيعالج الفيروس هذا؟
مثل ما قلت لك انا ماني خبير بالامراض التناقليه. معظم الحالات الحرجه اللي عم تتعالج بمستشفى الحريري الحكومي. ما بعتقد عم يعتمدوا على الهيدروكسي كلوروكوين. They have an excellent section of infectious disease, and actually the government has put together a crisis management team to help the Ministry of Health and help all the other hospitals defining the protocols for screening and for treatment. And that crisis team has quite a few prominent and excellent infectious disease people on it, including Dr. Mawad and I believe there's another infectious disease person from American University of Beirut, Dr. Youssef from St. George, and Dr. Dabar, I believe, from Hotel Dieu de France. And I believe they all have agreed on the protocol. I don't have the full details of the protocol. I wish somebody from the infectious disease section was with us. I don't think they are working with hydroxychloroquine, and I believe they are trying to secure remdesivir on a trial basis whenever they can secure it. I don't know, is George Ghanem on the George, are you with us?
Yes.
Oh, yeah, George.
At the University of Sao Paulo, we are not using chloroquine. We are not using chloroquine.
So what are you using in Sao Paulo?
Well, basically, we give support to patients and depend on each patient. We give it's the support therapy itself that cures patients. We don't have a specific. There are several protocols that Professor Esper Callas is responsible. He's not here today, but he's responsible for the protocols. There are several trials going on, but not specifically one therapy. And what I'm sure that they have a support therapy, and many times they use corticosteroids. That's the most important thing, I guess, at this point. But there's not a specific therapy, antiviral therapy that we give for everybody. I'm sure that we don't have an answer for that. And in particular, hydroxychloroquine is not given in patients when they are hospitalized in my university.
Yeah. As I said, there was a lot of enthusiasm about using a combination of hydroxychloroquine and azithromycin based on what came out on that very small study from Marseille from Professor Raoult. But right now, I think there have been bigger studies that say that it doesn't work, and if anything, it may cause some damage to the patient. Obviously, here they're using supportive therapy, but I thought the question was there any specific antiviral drug that may have shown more beneficial effect than others? I know of remdesivir, but I don't know about any other drug. There was another drug that came out of Japan, also another antiviral, but the name escapes me right now.
You may see in my Facebook a good speech of Dr. Ray Hashem about the use of remdesivir, and in my Facebook, my own Facebook, Robert Nemer. It's a very good speech about that.
Robert, remdesivir has been proven. The problem is it's still on a research basis randomized trial study. So it's not straight available for patients here in Lebanon. I know that our infectious disease folks have tried to get it in some other ways, but they have not had too much luck with it. You have to be on a randomized clinical trial to receive remdesivir.
Okay.
And also the cost is something, because it's very expensive. It costs like $4,000 per patient, $5,000 per patient. It's very expensive.
Yeah.
Doutor, não sei se ele levantou sem querer ou não. Antônio Roberto. Está com a mão levantada por acaso, tem alguma pergunta? Não. Eu acho que ele levantou sem querer. Any more questions from somebody? Please, people, we would like to listen more something about from doctors from Lebanon. Dr. Nastas or any other one, you want to tell us anything else about Lebanon?
Turn on the microphone.
Put it on. I will do it for you. You may talk to Patrice, please.
I guess there's nothing that we can specifically add that Dr. Mawad didn't say. except then we have to take into account the financial situation here in Lebanon. Plus, right now there's no real treatment. I mean, some places are trying to use hydroxychloroquine according to protocols established in the US. But all have agreed that, especially right now on the Medscape, they've shown us that remdesivir has no real impact. And other drugs are still on clinical trials. So there's nothing really specific that can help us.
Eu não sei. Aí são os que estão participando.
Hello? Hello?
Hi.
Yes.
Hi, this is Raja Shatila from Lebanon. I'm a gastroenterologist. I would like to ask, hello. I wanted to ask about recent literature talking about the use of aspirin in the treatment of the disease. Any experience in your part on the use of aspirin?
Dr. Michel or Dr. George? George Halaka.
There's also, I agree with Dr. Raja, with Shatila. There is a trend now also to use aspirin because there is an underlying thrombotic effect in COVID-19. And it's not clear whether it's secondary to the infection or coexistent with the infection itself. But I know in skin lesions, in biopsy, COVID-19 skin lesions, they have shown on the dermatopathology multiple areas of thrombosis in the blood vessels of the epidermis and dermis. And also on autopsy findings with lung lesions in COVID-19, they have found a much more prominent diffuse thrombotic effect. But the confusion in my mind, usually for a thromboembolic mechanism or diffuse thrombosis, especially pulmonary, we use anticoagulation, we don't use antiplatelet. So I don't know if the antiplatelet therapy, i.e. aspirin, how effective it could be if it is actually to treat a thrombotic phenomenon related to COVID-19. But I heard, much like Dr. Shatila, there is some, I believe, some anecdotal reports of using aspirin with beneficial results in the treatment of COVID-19.
What I can say is that Professor Saldiva from the pathology department has published a paper exactly say what Professor Michel has just said. There is a lot of microthrombi as the is very important, not in everybody, but let's say around 40% of patients have microthrombi everywhere, not just in the lungs, 20% having brain and the spleen, the kidneys. So it looks nice if you can start at early anticoagulant therapy. I just don't think that aspirin is going to be enough, like Professor Michel said. So one of the most promising fields in therapy, in early therapy, is to give this anti-thrombotic medications like heparin and so on. So aspirin is very easy, it's very cheap, but I just don't think that is enough to break the disease once it has started.
I agree with Jorge. I think you know, for thrombophylaxis, one has to go to anticoagulation. I don't think antiplatelet is enough. And there's also some reports, especially from the ICU setup, that the prone position, even intubated, the prone position is much better for the outcome than the supine position at the ICU.
Okay.
Yeah, that prone position proved to be very effective. That's true. That's very effective. I mean, it's a life-saving position in this situation.
Okay, thank you very much, Josh. Any more questions? I think that's all. Thank you very much, Professor Mawad. And I hope we have more meeting. And why not in Lebanon we have more contact between us, between all university, and especially now the Lebanese American University and the AMLB, it's Brazilian Lebanese Medical Association. وإن شاء الله نجتمع عدة مرات ونلتقي فيكم بلبنان ونعمل أعمال طبية واجتماعية بيننا وبينكم.
Robert, أنا بالنسبة إلي and on behalf of all the Lebanese physicians here in Lebanon بدي أشكرك على هالمبادرة الحلوة والسباقة لحتى تجيبنا كلنا سوا، وخصوصي تخلي همزة وصل بين الأطباء اللبنانيين والأطباء البرازيليين، خصوص الأطباء البرازيليين من أصل لبناني. نحن بنفتخر فيكم، بنفتخر بكل علاقات فينا قوية بيننا وبينكم، وخصوصي إذا تلاميذنا بيجوا بيتعلموا منكم كمان.
Renato, quer falar alguma coisa?
Yes, Professor Mawad, we really appreciate your lecture. Thank you very much. As a former president of the Brazilian Lebanese Medical Association, we are very grateful, and we hope we can continue our bridge, building our bridges stronger and stronger, because this is very important for us Lebanese descendants living in Brazil. Thank you very much for your lecture. I really enjoyed very much. Thank you.
I would like to introduce you, Dr. Walid Anderi, tá aí?
Sim, estou aqui.
Então, Walid Anderi is Vice President of the Association. Please, may you talk?
Thank you very much, Dr. Mawad, for your presentation. It was excellent. To share our experience is very important for here in Brazil and the doctors in Lebanon as well. Thank you, George Halak, for your explanation. It was excellent. And everybody that is a participant in this meeting, thank you very much. And we hope to have more meetings between us, Lebanon and Brazil. Thank you.
Inshallah.
I would like to inform you that this video is online or is live in Facebook. It may be saved in the Facebook in my page, okay? Thank you very much, everybody. Obrigado a todo mundo. شكرا. Merci beaucoup à tous. وإن شاء الله في المستقبل نرجع نحكي معكم.
Obrigado, Roberto. Obrigado.
Obrigado. Obrigado.
Obrigado. Bye bye.
Obrigado.
Tchau, Robert. Um abraço.
Obrigado.